All right, here's my mini lecture on deprogramming, or what we're trying to do. One of the biggest problems with early centric relation dentistry is that the proponents of it believed that the final act of closing as well as the first motion of opening was purely a hinge. And as we know, that's not true. Mapelli, using 3D coordinates of strategically placed markers and using 6 different cameras to triangulate, clearly showed that the first movement of opening is not purely rotational, but a combination of translation and rotation, with translation being most contributory, closest to MIP in both opening and closing. Now, neuromuscular speaks to finding a position that is driven by the stimulation of the root of the trigeminal nerve. And Dow looked at how this could actually work. And so they wanted to understand the mechanism, how the myomonitor worked. And what they found that really it was only the distal axons of the motor neurons that were directly stimulated. And the problem is with that is because the stimulus only acts in the periphery without participation of the central nervous system, the ability of this instrument to reproduce a reflexively controlled occlusal position was highly questionable. Another study that is listed by the neuromuscular people is a rather interesting one, and that's by Roux. And what Roux looked at was the vertical dimension of rest and rest after tensing. Now, there was an N of 15. I only used 5, and you could pick any 5 at random. The results were pretty much the same. And what they looked at, and they found rest position before tensing, and the purple bars are the distance between the teeth after tensing, and you can see that it's a pretty significant difference. And the only way you can get this type of posterior tooth separation is via Christensen's phenomena. In other words, that the condyle must translate down the eminence to allow the posterior teeth to separate. Interestingly enough, I had a patient come in that was worked up. They wanted new veneers, and they were worked up in a neuromuscular office, and I decided to get some CBCT images. The one on the left is her in her MIP. I apologize, my lab still calls MIPCO, but you can see a well-centered and seated condyles. The bite registration, the tensed bite registration, was also given to the patient, and the patient was asked to insert that, and the CBC was taken with that, and you can clearly see the position the condyles are now down and forward. So let's take a look at the preliminary study casts, and the casts you can see she's got maxillary veneers, molar to molar, and this is the wax up that I asked my lab to make from the mounted cast with the neuromuscular bite. And the only requirement I had in my lab was not to reduce any of the stone on the models and strictly wax additively. And this is the most interesting thing that you'll see. Look at the length that has to be added to the mandibular and maxillary incisors to make sure the anteriors would still couple. In other words, the vertical distance this patient has been open. Now, Mike Melkers, and I borrowed this slide from Mike, has done a number of interesting studies where he looked at hundreds of patients and with a black Sharpie have them wear their anterior deprogrammer, and you'll notice that they'll scribe out their parafunctional movements. And then he'll have the patient come back and he will insert some articulating paper, in this case red articulating paper, and ask the patient to go through their eccentric parafunctional movements. And if you notice the chevron difference on your right, the red versus the green, and this is the difference what we see on the patient. The red chevron is what the patient can do while awake. Well, the green actually represents what the patient will do at night. So the point being is voluntary range does not necessarily equal the parafunctional range in excursions or seating. Is the joint properly deprogrammed? And the question that's asked is if we restore in this position, the not fully seated position, will the patient parafuncture posterior to this and put our restorations under stress, possibly resulting in failure? So the real question is what do we want to do? How much muscle recruitment do we want, right? This is another study cited by the neuromuscular crowd, and it's kind of interesting how they perceive it, because I'll tell you how I perceive it. And what they did is they looked at the effect of different condylar positions, and its recruitment of the temporalis and masseter muscles. They looked at bimanually manipulated, leaf gauge, centric occlusion, which should be MIP, and a neuromuscular condylar position. And what they found is when the condyles were placed anterior-inferiorly in the neuromuscular position, the total muscle recruitment was the greatest. Now, they claim that this is a good thing because it shows healthy muscles. I claim, and I would think that most would agree, that this isn't necessarily the best thing you want to do to your knee restorations. So, at the end of the day, it is articulation that we're talking about. And what we have to recognize is that parafunction is the cause. Occlusal wear or breakage is the result of it. So in deprogramming, our goal is to find and accurately transfer the correct information to fabricate prosthetic components that'll meet all the requirements of a stable occlusion and not break.